Good evening, everyone. Greetings from Geneva. Lee Wallis, I'm the lead for emergency and critical care at headquarters in Geneva. Very briefly, emergency medicine by background, was in the Royal Navy, trained in Plymouth and Cardiff, and I was in Cape Town for about 20 years, and the last few years I've been in Geneva as part of a program that I'm going to tell you about. It's not going to be a clinical talk. It's not going to be a talk about our disaster response. That's a different part of WHO. We do, as you'll see, we have a bit of an overlap. So you're talking about, say, the trauma care provided in Gaza. We have a footprint in that, but we're not talking about the large-scale response to earthquakes and planning for COVID and things like that. Anyway, hopefully it's information that's interesting to you. It's a different, I'm sure a lot of your talks are about clinical care. This is really about our approach to supporting lower middle income countries, which is where the focus of our work always is. So I'm going to just run through why we take an integrated approach, take you through what our approach is, and then a little bit on how we're planning to scale going forward. So just to start, in terms of, this won't be so obvious from the UK, where you have a very well-developed NHS and trauma system. But in a lot of countries, the system is not designed around the needs of patients historically. So the fact is that how you organize the services and where you put the resources builds a pathway that creates across the system channels of movement. Now, if you have a well thought through system like the UK, then those channels are directed. So you have like your major trauma system, and you take patients to the place where you believe they'll have the best outcome as early as possible. That is not necessarily the case, but these channels get created. Sometimes they're good, like the UK, and sometimes they don't work well, and they need redirecting. And the problem is when they don't work well and they don't match user needs and preferences, then the users journey off path. And that not only causes a problem for patients much of the time in terms of delays in care and bad outcome, but it also is a problem for the system in terms of mismatch of resources and demand, overuse of budget, inability to deliver care at the level that the patients are presenting, and so on. And you may think this is part of the issue with overcrowding of emergency departments with patients who you believe could be seen in the primary care system, as an example. So with the background of thinking about matching services to patient need and thinking through it properly from the outset, you think from primary care through hospital-based care back into the community, much of that care delivery and that journey beyond the primary care component is either emergency care, critical care, or operative care, as in surgery and anesthesia. So we refer to it as eco-care, emergency, critical, and operative care. And it's the continuum from the community through primary care into hospitals. And there's good evidence that if you can actually integrate those services properly, then you get a lot more efficiency and effectiveness and economies of scale and economies of scope, and you can really centralize the expertise. Now, we know that emergencies happen every day, everywhere. There's a great quote from Olive Kobusingi, who was a trauma surgeon in Uganda. She said back in about 20 years ago in WHO Bulletin that emergencies occur every day, regardless of whether the system is prepared to receive them or not. So it's really incumbent upon us to make sure that the system can receive patients with emergencies. Now, as a trauma surgeon, she was focusing on trauma, but it is exactly the same system that responds to trauma and responds to other emergencies. And we know from the Disease Control Priority Project, which is a World Bank project that tells ministries of health what's cost effective and what has evidence behind it in terms of interventions. And we know from a couple of good modeling papers in BMJ Global Health and in EMJ that somewhere between 50 and 60% of deaths each year in low and middle income countries, that is all deaths, not hospital deaths or sudden deaths. Over 50% of all deaths each year in low and middle income countries, and over a third of disability each year, is from conditions that are amenable to emergency care. So if you have a better emergency care system, better trauma care system, you could significantly impact potentially half of the deaths each year. Why do we focus on injury beyond our focus on eco-care? And, just to stop for a second there, WHO is a public health organization. We've just turned 75. I didn't. I looked like I turned 75, but that's because I was flying all night last night. But WHO just turned 75, and for the bulk of that life, WHO is focused on public health in the well understood sense. But just before COVID, there was a shift to start to focus on clinical service delivery as well. And then, of course, COVID both delayed our development of our systems around that, but also strengthened them in unrelated, but sort of parallel, clearly related, but parallel streams. So it stopped one pathway and built a very strong pathway in terms of clinical services and maintaining them through COVID. Now, we have a clinical services unit, that's our unit, which I'll come back to, that is now really only a handful of years old and is now really the focus of our efforts in day-to-day systems, so not in the surge response, not in large-scale emergencies, but on a day-to-day basis. We are trying to match our products and support to countries to their need, and a lot of their need is driven by the burden of disease, clearly. And there's a huge burden in that of injury. So I've just said over half of deaths each year are from emergency conditions, but I think many of you will know this information already, that about 10% of all disability globally is due to violence. About 3.2 million people die of unintentional injuries each year. 1.25 from violence-related injuries, and 4.4 million overall due to injuries, which is still, and if you think about where funding goes from large funders, large global funders, you wouldn't believe this, but this is about 60% more than all deaths combined from HIV, TB, and malaria. So it's a massive global problem. It's 8% of all global deaths, and it's the leading cause of death in those aged 5 to 29 across the world, actually by quite a long way. And 3 of the top 5 causes of death, children, are injury, road traffic, homicide, and suicide. So we know this from multiple sources, and it's a problem that really is not being addressed. Well, it's not being addressed in the way that we would like from funders and research and investment in systems, in the way that we see with some of the more vertical infectious disease programs. And we're trying to change that through both technical support to ministries and advocacy. The other thing about the trauma care system or the emergency care system, it's the same system, is that it's very cost effective. So on the right here, if you keep someone alive for a year with antiretrovirals for their HIV, it's somewhere of the order of up to $1,000 a year. On the left, if you run a community ambulance service with formal paid medics in there, it's about a quarter of that to get the same year of life gained. And here in black, if you combine first responders who are volunteers with trained paid paramedics, it's almost free. It's $7. It's one of the most cost-effective interventions around. And we know that when you go into the hospital and introduce simple changes like simple training and triage systems, you get something around a 650% return on investment. So very cost effective. It's also exactly the same system that responds. So we saw during COVID, and we also see during conflict and earthquakes and so on, that you cannot maintain health systems if you don't have access through the emergency care system. So while we may be focusing on injury, it's exactly the same system that needs to perform to allow people to access care during times of stress. So there's a huge burden of disease that we're trying to meet and trying to direct our resources to support countries. But we also have a global mandate, and our mandate as a UN agency comes from our member states, so 194 countries in WHO. So I'm sure many of you know, but there's the United Nations, which is a member state-driven organization, and it has its UN General Assembly each year, and then WHO is the United Nations Health arm. And we have exactly the same. So we have 194 member states, and they tell us what we should do. So member states sit on our executive board and control the organization. We work for the government, and we are split across 3 levels. So we have headquarters, we have 6 regional offices, and then we have country presence in most countries around the world. At our annual World Health Assembly, we're given a mandate in the form of resolutions, and our resolutions, usually from ministries, are driven towards them trying to achieve the Sustainable Development Goals. So the SDGs replace the Millennium Development Goals, which run up to 2015. These run through to 2030. And in these goals, there's about 150 or so targets. We know that the emergency care system helps ministries to achieve about 10 of those targets, whether it's from deaths from infectious diseases or reducing deaths from violence and injury. We've had a range of mandates in the past that have told WHO that we need to focus more on surgery, on preparedness and response, and more recently on ensuring that emergency care systems are in place. And this one at the bottom, 7216, came in just before COVID. So while it was a very powerful mandate to tell us to focus our attention there, we then were obviously completely distracted into COVID. So last year at the World Health Assembly, we had 76.2 at the top of the screen, passed by the member states. So this is our current resolution that we're working under for the next 10 years on emergency, critical and operative care, both for day-to-day service delivery, but also as the basis to be able to respond in a large-scale emergency. Resolutions do 2 things. One is they tell WHO what we have to do to support governments, and the other is they tell governments what they could do if they wanted to follow the recommendations to improve their system or the delivery, depending on what the resolution's about. So 76.2 lays out in bullet points what we have to do, where we have to support countries. We have to produce guidance on this, we have to collect data on this, and then it guides ministries. If you want to support pre-hospital care, these are the sort of things that you could invest in or that you could do. One of the things that often follows a resolution, particularly when it's in an area that is quite a new focus for countries, is we develop a global strategy and action plan, which really lays out over, in this case, it's going to be presented in May. It just passed our executive board in January. So this new resolution will tell us that by 2026, we have to have produced a global strategy to support countries to have better integrated emergency, critical and operative care. And when we say that, of course, for this audience, we are talking that trauma care should be supported through that, from pre-hospital through the emergency department and ICU and into surgery and beyond, into rehabilitation and back into the community. But of course, again, it's the same system for maternal emergencies, pediatric emergencies, and so on. Okay, so there's a burden of disease, we have a global mandate. So what do we actually do in response to that? How do we, as an organization, try and address across the 3 levels of the organization? How do we try and address this need to support our member states? Well, one thing we do is try and help countries achieve universal health coverage by providing them support on developing their policies and their service packages. And the service packages really are what you should provide at which level of the service for what conditions and what population groups. And we'll come back to that. We support them with pathways to care, so how you move across the system from primary care up to tertiary care and back as needed. And then we work on supporting clinical service delivery. So the unit that I'm in, and I see in the participants, one of my team lurking there, keeping an eye on me. We are in a unit called Clinical Services and Systems at headquarters, and we work on all of these areas. So models of care, how your health system should best be put together to meet the needs of your population, how you should move up and down the system, so referral and counter referral, what should be available at each level of the system for both major disease groups and then across the life course, how hospitals fit into the health system best. So what functions should be available in a hospital, what a hospital should do, how it should be governed and financed, how to provide clinical care. So in primary care, emergency, critical and operative care. We also have cross-cutting themes on trauma, just special interest or special area of focus for us, as is sepsis, as is palliative care. And then we have a whole range of educational products that you won't be aware. I'm sure many of you will know advanced trauma life support, for instance. Many of you will know PTC, primary trauma care. We have a series of learning programs, a couple of which are out and about in the wild, so to speak, out there for the public. But most of them are about to be launched over the next 6 months or so, maybe 12 months, across the whole range of eco. This is how we think about emergency care and trauma care. Keep it very simple. As I said, I'm an emergency doctor by background, so I have to keep simple. I don't get past the first part of the alphabet, ABC. And so in order to actually be able to support ministries properly, we have to be able to get our heads around what it is we're doing. So we make the system in 3 parts. There's the things that happen at the scene so that you can get care and you can be supported while you're waiting for care. And there are certain things that should happen around communication, around data, around personnel, human resources. Then there's things that should happen in an ambulance as you're being transported. And there's things that should happen at the hospital, both when you arrive and then in the care that you receive through the emergency department and into the hospital more deeply. Behind this very simple looking infographic is a very complex health system building block framework. And we use that to both map the tools that we develop to support countries, but also to help countries strategically plan to improve their emergency and trauma care systems. We also have another fairly powerful stream of work that involves WHO, but also is much bigger than us. The whole United Nations just had a decade of action on road safety and now has a second decade of action on road safety. So the first one started at 1.25 million deaths a year, aiming by 2020 to get down to 625,000. We actually started this decade of action at 1.35 million, and you may think that that's a failure. But actually, in that time, the population increased by something close to 1 billion. And the number of vehicles on the road increased by 2.2 billion. So there's a lot more road users. And also a lot of countries started collecting better data on their road deaths. So it seems like a failure, but it's not really. It's most countries achieved a reduction in road deaths over the last 10 years and continue to do so. Anyway, the post-crash response is framed around the emergency care system as well. And so it gives us, beyond WHO, it actually gives us some work streams with other large global agencies who are focused from injury from road crash perspective, but it's really, again, the same emergency care system. Okay, so I said we do packages, we do pathways, and then we do clinical services. So we have various tools that help governments to work out what package they have. So, for instance, for injury, a ministry planner would go into injury and say, okay, I want to select certain interventions that should happen for thermal and chemical injuries, burns. And then when you expand that, you get to say what should happen at primary care, first level hospital, second level hospital, in the ambulance service. And you can choose both the interventions that you undertake and the medication and equipment that supports that. So if you say you want to do escharotomy, this tool will automatically say, therefore, you need these medications, local anesthetic, pain relief, so on. You need this equipment, and then you need this training for the staff. And this should be done by this level of staff, doctor or clinical assistant. So that is mapped completely across the whole emergency care, injury care, sepsis care. It's very powerful for countries to actually think strategically about how they want their services to be designed. Parallel with that is thinking about how people move from the point of illness, or in this case, injury, into the system and then back to the community and productive life. And so we have tools that can help to assess your pathway and work out where your challenges are. What are the barriers to people being able to access care at, for instance, a first level hospital, district hospital, emergency unit? So is it that there's no protocols? Is it that the staff aren't trained? There's equipment, but it's broken? They can really break down to a very granular detail where the challenges are. And, excuse me, excuse me, not only work out what the barriers are and where they are in the system, but the tools allow them to then cost the interventions that they select to prioritize. So they could say, okay, we're struggling to identify the sickest patient, so we should have a triage tool, and we can work out with them what it would cost to roll out that triage tool at the level of care that they've selected across the country. And maybe they choose triage is going to cost $1 million for the whole country, and identifying patients at risk of sepsis is going to cost $2 million, and they trade them off and decide that they're going to invest in triage at this point until they have funding for the other. But probably of much more interest to this audience is how we support clinical work, right from the community all the way to the facility. So starting in the community, it's not really our remit to train on first aid. It's much more a Red Cross sort of intervention, but we have a first aid course that teaches first aid, but is much more about how you link to the emergency care system. So this is trying to establish these informal pre-hospital systems where the number of ambulances is very limited. Very standard ABC approach on trauma, difficulty breathing, shock, and altered mental status. And we have a version of this that is quite focused on conflict-related injuries. So for areas suffering from or with high risk of conflict. We have a course to train basic ambulance medics. That all of our courses follow the same approach. They use the same language. They use the same illustrations. They use the same visual design. So that from a pedagogic point of view, learners really have consistency and improves uptake. We have a wide range of pre-hospital tools to support countries, including, for instance, clinical protocols across a range of conditions. This is the basic ambulance provider pre-hospital protocol for trauma. Then our core course, and I say that not so much that it's the center of our activities, but it was the first one that rolled out in 2016. We've trained with Red Cross over 20,000 people on this course now. We've recently introduced a conflict module on that with a lot more depth on burn, blast, and penetrating injury, which has already had something like 15,000 people take it on one of our online platforms. Basic emergency care was co-developed with ICRC and the International Federation for Emergency Medicine. And it goes through the same approach as the community first aid. So ABC, trauma, difficulty breathing, shock, and altered mental status. It is basic, it's intended to. So for instance, you will learn how to do a needle decompression, but not put a chest tube in. You'll learn how to put an oral airway in, but not intubate. So it takes providers so far, and it's been incredibly popular, and I'll come back to the impact of that. We have other tools that I'm not going to dwell on, but triage to identify the more seriously injured patients, tools to help hospitals to bring together the resources that they have with no extra investment and just organize them in such a way that the sickest and most seriously injured patients are seen what you'll know as a resus area, but that's not a widely understood term in many, many countries. We have checklists. This trauma care checklist, for instance, was used in 11 hospitals across a variety of resource levels and showed a, not statistically significant, but still showed a 50% mortality reduction just by stopping during resuscitation and saying, have we checked for attention pneumothorax? Have we got IVs in place? Things that commonly are forgotten and lead to bad outcome if you don't do them. these checklists, just like a flight checklist, really increase safety in the emergency department. And then standardized clinical forms following a similar sort of idea. If you're not trained in ATLS or similar courses and you don't know to manage patients A, B, C, D, E, but you have to start writing in that way. If you start writing your clinical notes that way, it changes your behavior and it improves clinical outcome. Okay, so there, emergency care. So community first aid response, some materials, including training materials for ambulances, basic emergency care, and what we call the emergency care toolkit. So basic emergency care with triage and the checklist and the standardized forms. We have a new course which is about to come out, which builds on basic emergency care and takes you into ongoing care. So it's called basic critical care. And this takes you really up to the point when you are ready to be admitted to an intensive care unit, for instance. We are bringing out a trauma course that builds on basic emergency care as well, with some more advanced procedures such as escharotomy and intraosseous and intubation. We have a series of resources for mass casualty management, which may be of interest to some of you, including learning programs and then modifications of trauma care checklists and so on that can help people provide care during a mass casualty incident. And we have a simulation center in Lyon in France with the support of the French government. We're launching in October our flagship WHO Academy, although you can find courses on there right now. At the temporary academy site in Lyon, we have this mock emergency department where we can run mass casualty drills with hospital staff from anywhere in the world. And then for those of you who are surgically or anesthesia inclined in the audience, these are screenshots from the upcoming launch on the Academy of our operative care work. So for about 20 years ago, we produced two really fundamental textbooks. One is surgical care at the district hospital, and one is anesthesia care at the district hospitals. And they've been a huge guide for clinicians, non-specialist clinicians, particularly in district hospitals in rural areas, in low-income countries particularly. This is all getting updated and will go on the Academy, as well as like all our courses, being available in a face-to-face version. And you'll see there's a whole sub-course on operative care for injury. So we'll be able to take people from when someone's injured, WHO courses and materials will help someone in the community provide first aid for them and access the system. They'll help the medics know what to do and also be supported with protocols and other SOPs and so on to help them provide trauma care. When they come through the emergency department with basic emergency care training, the advanced trauma course and basic critical care training, we keep them alive and stable and then undertake the surgery and the post-operative care. So we are very excited that this is coming out. This is my excited face. For those of you who might know me, this is about as excited as I ever get about anything. So this stuff is going to come out over the next months. And this is really the first time that WHO has had clinical guidance in these areas. So for instance, we have no guidance on heart attack and stroke. What we do have, again, because we are a public health organization, we have tremendous guidance on things like Ebola and malaria and so on. But the things that you would see, like injured patients or those of you working in emergency, the range of emergency conditions, that's a gap that we're now starting to fill with all of the guidance that comes with these learning programs and tools. And again, surgeons amongst you will recognize the Safe Surgery Checklist. I'm sure it's used widely in the UK, and there are a number of other surgically oriented tools that we have available. And they're all going through a review right now and plan to be reviewed and updated in new versions as needed over the next couple of years. Also have some guidelines for countries on, these are some of the first things that we produced on trauma care way back about 20 years ago. And these are all getting updated right now, both in terms of service packages and what should be available, but also guidelines to help countries and facilities particularly to institute quality improvement programs. So it will no longer be focused on trauma. It will be about quality improvement programs in general across the ecosystem, but this will be out probably by the end of the year as well. And then finally, around quality, we have a clinical registry. It started as the International Registry for Trauma and Emergency Care with a trauma care module and an emergency care module. So the trauma care module captures most of the emergency care detail, but then runs through into the theatre stay and so on. The emergency care module also picks up other common emergency conditions. Any of you had the fortune to go there? We were at the Utstein Abbey in Stavanger in Norway to finalize the work on the emergency care module. But we'll also, within a few months, be launching the operative care module as well for operating theatre registry, and then followed at some point by sepsis and critical care modules. So that is a lot of information, I'm well aware. We'll slow down a second and think about why we're rolling out all of these things. 70 years of doing public health, and then this not a tilt really, was the organization is like a oil tanker, and quite rightly, it's 90% of its focus has to be on public health, and including in there the WHE side, the emergency response side, which is taking more and more as the world becomes a more complicated place. But why have we made this explicit decision to start to focus on clinical care provision and how it supports universal health coverage and day-to-day systems? So one huge piece of evidence that motivates me every morning and gets me to go to work and try and push through and get this content out there in the world is the evidence that we got from an almost 40,000 patient study across 17 hospitals looking at patients who are injured and had a number of other conditions. And we found that we had a persistent of the order of 50%, in fact, on average 50% mortality reduction, 48% mortality reduction in injury, 44% pneumonia, 48% in asthma, 75% in diarrhea in small children, 60% mortality reduction in under 5s, 60% mortality reduction in under 18. So it's just the same as the modeling that I mentioned earlier. The models suggest that emergency care can impact half of deaths. When you study it, when you take a low resource hospital, you rearrange what they already have there so that they have a resus bed. You introduce a triage tool so that they can identify the sickest patients. And you train people on these basic courses that take 5 days, and the whole thing in a hospital costs about $4,000. You save 1 in 2 lives going through that hospital. With that sort of impact, never mind the global mandate, with that sort of impact, we really are obliged to do something about it. So we've launched what's called the Acute Care Action Network, where WHO organizes this formal network of partners, stakeholders, funders, and so on, who their focus through the network is to take these key findings in acute care to scale. So you can find out about the network, and I'm more than happy to share these links, but you can find out about the network online. And a lot of the professional organizations that you may be associated with are already members. The only real, so trauma care, for instance, may be interested in joining. The main consideration is whether you are working internationally. So if you're working beyond your own country, then you'd be eligible to apply to join. And our priorities for the next couple of years are to roll out that toolkit, which has this massive mortality impact, expand the work on services and readiness around helping ministries to align their services to population need, training communities in first aid, but also trying to get better use of the health system from communities, trying to work out with the community when they should seek acute care and when at a hospital, and when they should seek it with, say, a traditional healer or a community health worker. Clinical quality improvement programs at facilities, and then strategic planning with ministries. That's our focus areas for the next few years. And one of the key agents for that, for injury, will be the alliance that we've had around for 10 years now, the Global Alliance for Care of the Injured, which was really a precursor a decade ago, before we had these resolutions to drive our work. This was a precursor of the Acute Care Action Network we now have. One other initiative that we've launched, again, on the back of such impactful data, and we know that 70% plus of the health workforce globally is nurses, and they provide the bulk of emergency care worldwide for injured patients. Sometimes nurses are the only providers that a injured person will see in a facility before they get referred on somewhere else. Nurses run or provide care in ambulances in many, many countries. But they are not getting trained in emergency care. And if we look at the tens of thousands of people who've been trained on basic emergency care, for instance, only about 20% of them are nurses. So we have a focused initiative to improve access to this training for 25% of nurses and midwives in 25 countries by the end of 2025. So we're very excited about that campaign. There is an email at the top there. This is our emergency care toolkit website, but you can see there emergencycare@who.int. By the way, it's only really the UK. It took me a long time when I moved over. It's only the UK that calls us the WHO. We tend to be called the WHO. I don't know why, but emergencycare@who.int, and it will come through to either me or the team member who's lurking in the participants here on this webinar, and we'll get back to you with more details on anything that you want to see. Anna, I'm going to stop sharing there, and I'm happy to do whatever you direct me to do.
Wonderful. Okay, so I'm just going to share my screen again. So before we move on, let me just double check that I've got the correct screen sharing. I do. Excellent. So before we move on, as I mentioned earlier, we do have a double header of a webinar coming up in 2 weeks' time. I'm going to ask Emma to facilitate this one because I am not here. But we do have the wonderful Wasim Ahmed with us talking about the elephant on the road, emotions in pre-hospital care, part 1, the patient encounter. So as I said, this is part 1 of 2 different separate webinars. One's talking about pre-hospital and all about sort of what you can expect with patient encounters, the emotions that you feel as pre-hospital practitioner dealing with those patients. Especially we're looking at this one, hence the photo, pediatric care in pre-hospital situations and how to deal with your emotions in that. And then part 2, we're going to be looking at the after effects as well of the care. So we're kind of looking at the patient journey all the way through and your own personal journeys as practitioners in that as well. So moving on, just straight away to answer a question that has popped in from anonymous attendee. How are we able to get the CPD certificate if we are not a trauma care member? Well, dear anonymous, this is how you get your CPD certificate if you're not a trauma care member. So if you're not a trauma care member, do scan the QR code that's on your screen right now. This will take you through to a type form for you to fill out. You pay a simple $1.99 and a CPD certificate will be sent straight to your inbox the second that you click submit. Do check your spam as well, and it will be in there. So that is how you get your CPD certificates. If you are a member of trauma care, please do not scan this QR code. You will be sent a certificate tomorrow, automatically free of charge. If you do want to become a member, you can go to the website at the bottom of your screen, which is traumacare.org.uk/members. You can sign up from just £3 a month. So it's literally £1 more to become a member, and you get all of your CPD certificates for free for life. So Q&A time. So let's have a look. We've got a few questions here. So Lee, the first one that's come in is from, I've lost my mouse again, I do apologise, is from Ali. So Ali is asked, it is well understood that many patients present very late with disease processes that require surgery because they cannot afford healthcare costs. The catastrophic expenditure to pay for surgery worldwide was researched and documented in 2015. Schreier et al. Wonderful phrase question. Is this the same for trauma care?
Yeah, thanks, Ali. Great question. And in fact, the protection against catastrophic expenditure is one of the key things that we strongly advocate to governments to be in their regulatory frameworks, their legislation. I just came back from an East African country overnight, and we were having explicit discussions about that. The emergency and essential surgeries that countries are sort of mandate is a bit strong, but somehow expected to provide would be emergency cesarean section, emergency laparotomy, and then washout and fixation of an open fracture. So two of the, clearly the open fracture is injury, and laparotomy is often for injury. So very much it's the same for trauma. There is a a huge problem globally, not just in low-income countries. So there are some high-income countries that also have a problem with this, with financial ruin from just being unfortunate enough to be injured. So it's something that we're very aware of, and we have both our governance department that tries to work on it, but also as we deal with clinical services with countries, we make a big point about this. So yeah, thank you for asking that.
Wonderful. Sorry, I just had to stop sharing my screen because I clicked something and everything started playing in my ear then. I don't know what was, I don't know whether it was coming or going. So let me just share this screen again. And yes, please do get your questions in now, everybody, as this is the time for said questions. Ali again has asked another question, which is sort of on a similar vein. Let's just get this up. There we go. There we go. On a similar vein, is there a way to be of being involved in the operative care module?
Yeah, Ali, I guess it depends what you mean. So in terms of content development, we work with professional societies, global professional societies. So for instance, the trauma surgery course is done with IATSIC, the International Association for Trauma Surgery Intensive Care. They produce the content with the editorial function on it. We have peer review of that, and then we get final sign-offs through we have what's called a technical advisory group. So our group of experts, which is some family medicine, primary care, nurses, doctors, some emergency critical care, and then surgery anesthesia. They sign it off, and then it's out. So in terms of content development, no, because it's done through a very formal structure, but also it's done. But in terms of rollout, absolutely. What we do with courses, really, we are not an implementing organization in terms of training. We're changing that a bit with this academy now, and I'll come back to that with the next question I see. But really, we put the course out there. We put it on our website. It's completely open source. You can take it and teach it. So the intention is that it is a trade-off, of course, between quality assurance and access, but we really focus as much as possible on access. So we put the course out there, and we want professional societies to go teach it. We want academic institutions to go teach it. We want volunteer organizations to go teach it. So in that sense, Ali, you can absolutely do that. But please just drop an email again. If you're surgically oriented, send it to surgery@who.int or emergencycare@who.int. Either of them end up in my inbox anyway, so it'll be me or one of the team that come back to you. And it's a very small team. There you go, surgery@who.int.
Wonderful. Thank you very much. Thank you. So someone's just, I'll just answer this. Julius has said, how I hope this can be done again. Don't worry. There was a lot of information to digest, but that's the point of webinars. It's to learn a lot in a short space of time. However, if you want to rewatch this, it will be available online afterwards, Julius. So you will be able to redigest everything again online next week when I'm back in the office. So Danny Grace has asked, I like a lot of the patient record paperwork and check sheets. Are these available on your website? Are the academy courses online or in person, which you've kind of answered? And a very interesting presentation. Thank you. So the crux of that is, are the paperworks, the check sheets, are they all available on the website?
Yeah, I guess there's two parts. So the paperwork and check sheets are all available on the website. So if you look back through the recording, you'll see the website. My last slide with the email address on, you'll see the website at the top. So if you look for our emergency care toolkit website, you'll get a bunch of the paperwork and the tools that all there, open source. You just download it. Some of them are not publicly facing yet. So again, drop me an email if you like. For instance, the sheets for the emergency department are available. The sheets for the operating theatre are not yet. The ones I've shown you are, but the standardized charts, things like that, we're in development. So I can tell you about those. The academy courses, there's an academy platform, an LXP, a learning platform. It will only hard launch in October. It has soft launch now, so you can find the material. If you just search WHO Academy, you'll find it. On there, there's the basic emergency care course right now, and the mass casualty course, plus another 20 courses from other departments. Anna.
Wonderful. Thank you very much. And Julius again. Thank you, Julius, very much. So many developing countries lack pre-hospital care systems. How is WHO, or as us English people call it, WHO, helping to establish these, knowing very well that EMS is the foundation of the healthcare system?
Yeah, and I've worked out to see the questions as well, and I see Julius as well.
Excellent.
Last time I shared a forum with you, you were developing EM and EMS standards while at AFEM. So yeah, I was at AFEM, Julius, and at the African Federation for Emergency Medicine. We're still very actively involved. If you go to AFEM's website, you'll find all of their work. But really, AFEM came into existence because WHO weren't doing this work, but we are now. And I transitioned from Cape Town to here, but we have a very active work stream on that. So AFEM really implements our tools. Pre-hospital systems, yeah, I only showed you a couple of slides, but we have a whole toolkit around pre-hospital care. It's a big focus of what we do, both in terms of trying to get the community to provide emergency care, but also in terms of supporting formal ambulance services. So we have standard operating procedures and protocols and equipment checklists, things like that you should have in an ambulance, how you should set up and run an ambulance service. Julius, drop me an email. Very happy to share that with you. Anna, then can I answer the question about Palestine?
That's completely up to you. I was going to leave that one to you. I'll just quickly jump in about from the anonymous. The payment process for tonight's appears to have frozen. That shouldn't have happened because it's linked up to our bank account in the background. But after this webinar's finished, I'll quickly check if it's not working for anyone else. Please do shout out so I can tell if it's just a one-person situation or if it's happening across the board as well. But I'll quickly check our forms and make sure that it's all linked up properly and that nothing's been stopped. But hopefully I can fix it if it is happening to more than one person. But try refreshing the page, turn it off and on again. Go IT crowd on it. That might work as well. But yes, over to you.
So it's not a difficult question to answer. I mean, the bit about Palestine is not difficult. WHO is a large organization. We employ 8,000 people. We are actively involved in Palestine in providing emergency and trauma care. We're actively involved in trying to build capacity of those clinicians who are still in Palestine. So we are providing educational materials to them. Absolutely. We're also involved with trying to support them with clinical tools that are conflict oriented. We're also doing the same with Israel. Israel has a better developed health system, so they have less demand generally for our services or support, but we offer, we're a completely neutral body. But absolutely we're involved in Palestine, both from the day-to-day team, but also our Eastern Mediterranean regional office is very actively involved in terms of trauma care supporting. Okay, thanks, Anna. I think the other question's for you.
Yeah, and one's just come in for yourself as well. Refreshing several times, but without success. Try a different browser, possibly. I know there are sometimes, for some reason, depending on what you're using, we use Stripe for the type form that we use, and sometimes Stripe doesn't like certain browsers. So if you could do that for me and let me know. But so far, this is the only report. This is the only report I've seen of it being frozen. So try that again. And Jason, just to quickly, just joined. You will receive it automatically tomorrow. Thank you for joining Trauma Care as a member. If that's what you have done, so yeah, you will receive it automatically. You don't need to do anything. And from Chisholm, a last question. How is the WHO getting countries to focus on emergency care alongside already established public health interventions?
Yeah, that is like the story of my life. How do you get ministries to focus on the thing that you really believe in? The evidence that we have now is really helpful. So we go to countries and say, like, do you want to save half of the mortality at your hospital? But also, what's been the most powerful thing is COVID. COVID was remarkable, of course, in having countries say, crap, we need to focus on what is it when something like that happens, which part of the health system is it that responds? So in order to be able to do that, you have to be able to work on a day-to-day basis. So from many, many years knocking on ministries' doors outside WHO, now we have ministries saying they want this support, and that's why we exist to support ministries in their priorities. So the prioritization has changed a lot, but thanks for the question. And thank you, Anna. I'm going to turn myself off.